Hi friends! In today's video, we're going to talk about fluid and electrolytes. If you like this video, make sure to give it a thumbs up and subscribe down below. I come out with new content every week for nurses, nursing students, and pre-nursing students. But let's get into fluid and electrolytes, and also make sure to check out in the video description some free resources as well as an NCLEX study guide. And there is also a free fluid and electrolyte study guide, which you will see in this slideshow. And you can get that down below for free as well. But let's get into it. So fluid and electrolytes. So an important concept to understand when discussing fluid and electrolytes is homeostasis. And this is a process which the body uses to maintain balance. And it's going on constantly. It is when the body adjusts for internal and external stimuli. So the body also uses a negative and positive feedback system. So feedback is the relaying of information about a given condition to the appropriate organ or system. Negative feedback occurs when the body reverses an original stimulus for the body to regain physiological balance, again, that homeostasis. And positive feedback enhances or intensifies the original stimulus. An example is blood pressure control and maintenance of body temperature are examples of negative feedback, while blood clotting after an injury and a woman in labor is an example of positive feedback. So systems involved in feedback are the nervous system, which regulates homeostasis by sensing system deviations and sending nerve impulses to appropriate organs, and the endocrine system, which uses the release and action of hormones to maintain homeostasis. So within the body, there's also body fluids, which make up a large portion of the body. Approximately 50 to 60% of our total body weight is body fluids. So these body fluids are in 3 locations. So there is the main compartments. The body fluid is divided between 2 main compartments, the intracellular fluid and the extracellular fluid. So the intracellular fluid functions as a stabilizing agent for parts of the cell, maintains cell shape, and assists with transport of nutrients across the cell membrane in and out of the cell. The extracellular fluid mostly appears as interstitial tissue fluid and intravascular fluid. So fluid regulation mechanisms. So there is first the thirst center in the hypothalamus of the brain, which stimulates or inhibits the desire for a person to drink. There is antidiuretic hormone, which regulates the amount of water the kidney tubules absorb and is released in response to low blood volume or in response to an increase in concentration of sodium and other solutes in the extravascular fluids. There is the RAA system, also called the RAS. This controls fluid volume, in which the blood volume decreases, blood flow to the renal juxtaglomerular apparatus is reduced, thereby activating the RAS system. And atrial natriuretic peptide, which the heart also plays a role in correcting overload imbalances by releasing atrial natriuretic peptide from the right atrium. So normal intake and output. So an adult human at rest takes in approximately 2,500 milliliters of fluid a day. Approximate levels of intake fluids include 1,200 milliliters from food, and approximate levels of intake include 1,200 milliliters of fluids, 1,000 milliliters from food, and metabolic products are 30 milliliters. The daily output should be approximately equal to intake, and normal output occurs as urine, breathing, perspiration, feces, and in a minimal amounts of vaginal secretions. So overhydration and edema. Overhydration is an excess of water in the body, and edema is the excess accumulation of fluids in the interstitial tissue space, also called the third space fluid. Causes of edema can be caused by disruption of filtration and osmotic forces of the body, circulating fluids. And treatment of edema is usually diuretics, which are used for systemic edema. There's also dehydration, which is a deficiency of body water or excessive loss of water. External causes include prolonged sun exposure, excessive exercise, diarrhea, vomiting, and burns. And treatment of dehydration is usually supplemental fluids and electrolytes. So let's talk about electrolytes. So an electrolyte is a substance that will dissociate into ions when dissolved into water. They are found in forms of inorganic salts, acids, and bases. The active chemicals in electrolyte concentrations are measured according to their chemical activity and expressed as milliequivalents. Each chemical element has an electrical charge known as an ion, which can be positive or negative. Intracellular electrolytes are potassium, magnesium, sulfate, and phosphate, and the most dominant cation is potassium, while the most dominant anion is phosphate. Extracellular electrons are important, such as sodium, chlorine, calcium, and bicarbonate, and the most essential cation is sodium, while chlorine is the most essential anion. So let's talk about some fluid and electrolyte transport. So the body cells, nutrients and oxygen should enter body cells while waste products should exit the body. The cell membrane separates the intracellular environment from the extracellular environment, and the ability of the membrane to allow molecules to pass through is known as permeability. We're going back to anatomy and physiology. So the permeability of membranes, there are freely permeable membranes which allow most any food or waste substance to pass through, and there's selective permeability. So these cell membranes are selective, meaning that each cell membrane allows only certain specific substances to pass through. So there is passive transport, which mechanisms include diffusion, osmosis, and filtration. Diffusion, or the process of being widely spread, is the random movement of molecules from an area of high concentration to an area of low concentration. Osmosis is the diffusion of a pure solvent, such as water, across a semi-permeable membrane in response to the concentration gradient in situations where the molecules of higher concentration are not diffusible. And filtration is the transport of water and dissolved material concentrations that already exist in a cell. All right, so now let's talk about active transport. So the mechanisms for active transport is that it requires specific enzymes and energy expenditure in the form of ATP. Active transport process can move solutes uphill against the normal rules of the concentration and pressure. So active transport is using that ATP to move the molecules in a direction that they wouldn't normally move when it comes to an area of high concentration to an area of low concentration, right? Because they want to find that homeostasis. So we can see in this next slide. So passive transport wants to move molecules from an area of high concentration to an area of low so that it equals out, right? So we get that homeostasis. If for whatever reason the semipermeable membrane wants those molecules to move in the opposite direction, it's going to require energy in the form of ATP. So we can see that here. The top picture is the passive transport, and this is diffusion, which is a type of passive transport that is moving the molecules from an area of higher concentration to an area of lower concentration so that the molecules on each side of that membrane are equal. However, with active transport down at the bottom, we can see the 2 green molecules are being moved to the area that has a lot of green molecules. And for that to happen, we need energy, which is using that ATP, which is energy. So fluid and electrolyte balances, there's osmolarity, which is the property of particles in a solution to dissociate into ions. And there's electroneutrality. This is the balance of positive and negative charges. So let's talk acid-base balance. This is another important concept of homeostasis. So acid, bases, and salts. So an acid is one type of compound that contains a hydrogen ion, and a base or alkali is a compound that contains a hydroxyl ion. And a salt is a combination of a base and an acid that is created when the positive ions of a base replace the positive ions of an acid. And important salts in the body are sodium chloride, potassium chloride, calcium carbonate, calcium phosphate, and sodium phosphate. So we can see down at the bottom, this should say acidic, but bear with me. So potential of hydrogen. So pH is a symbol that refers to the potential or power of hydrogen ion concentration within a solution. If something has a low pH, the number is lower than 7 and the solution is an acid. And if it has a high pH greater than 7, a solution is basic or alkaline. A neutral pH is 7, in which the solution would be neutral. And a change in pH of a solution by 1 pH unit means a 10-fold change in hydrogen concentration. So again, this is supposed to say acidic on the red side, but as you can see at the bottom, this just shows a nice example of an acid versus a base, or acidic versus alkaline. And again, that neutral is right around 7. So there's also buffers, and a buffer is a chemical system set up to resist change, particularly in hydrogen ion levels. There is the bicarbonate buffer system, so sodium bicarbonate and carbonic acid are the body's major chemical buffers. Carbon dioxide is the major compound controlled by the lungs, is CO2, and the respiratory system can very rapidly compensate for too much acid and too little acid by increasing or decreasing the respiratory rate, thereby altering the levels of carbon dioxide. There's also bicarbonate ions are basic components of the body, and the kidneys are key in regulating the amount of bicarbonate in the body. Measurement of arterial gases, so the pH level and amounts of specific gases in the blood indicate if there is more acid or base and their associated values. There is respiratory acidosis, which occurs when breathing is inadequate or the partial pressure of CO2 builds up. There's also respiratory alkalosis, which occurs as a result of hyperventilation or excessive aspirin intake. There's also metabolic acidosis, where the metabolism is impaired, causing a decrease in bicarbonates and building up of lactic acid. And there is metabolic alkalosis, which occurs when bicarbonate ion concentrations increase, causing an elevation in blood pH. So classification, so there is a fluid volume deficit, or also called hypovolemia, which occurs when a loss of extracellular fluid volume exceeds the intake of fluids. So we're losing a lot of that extracellular volume. There's also fluid volume excess, or hypervolemia, and this refers to an isotonic volume expansion of extracellular fluid caused by abnormal retention of water and sodium in approximately the same proportions in which they normally exist in the extracellular fluids. So again, fluid volume excess, we're retaining that water. All right, so these are pictures of the free electrolyte study guides that you guys can get by checking out the link down below. This is a great resource to study and memorize the different electrolyte imbalances. So one of the first and most important electrolyte imbalances is hypokalemia and hyperkalemia, so imbalances with potassium specifically. There are different things that you're going to see for both of these. So hypokalemia is anything less than 3.5, and potassium is always linked to cardiac abnormalities. So cardiovascular, you'll see a thready, weak, irregular pulse. You'll see orthostatic hypotension. Respiratory, you'll see shallow, ineffective respirations due to skeletal muscle weakness and decreased breath sounds. Neuromuscularly, you'll see anxiety, lethargy, confusion, coma, skeletal muscle weakness, leg cramps, loss of tactile discrimination, paresthesia, deep tendon hypoflexia. Gastrointestinally, you'll see decreased motility, hypoactive bowel sounds, nausea, vomiting, constipation, abdominal distension, and paralytic ileus. EKG changes for hypokalemia, you'll see ST depression, shallow, flat, inverted T waves. Risk factors are loss of potassium, inadequate intake of potassium from fasting and PO, potassium moving into the cell, so hyperinsulinism and alkalosis, dilution of serum potassium, so IV therapy with calcium deficient solutions or water intoxication. Our nursing interventions are to give an oral potassium supplement, liquid potassium chloride, potassium retaining diuretic, and it's important to know that potassium is never administered by IV push, IM, or subcutaneous routes. IV potassium is always diluted and administered through an infusion device. And foods with potassium include avocados, banana, carrot, fish, orange, potatoes, pork, beef, spinach, and tomato. And then we have hyperkalemia, so this is anything over 5. You will see cardiovascularly a slow, weak, irregular heart rate, decreased blood pressure, profound weakness of skeletal muscles that lead to respiratory failure, early muscle twitching, cramps, paresthesia. In late hyperkalemia, you'll see profound weakness, flaccid paralysis of the arms and legs. You will also see increased motility gastrointestinally and hyperactive bowel sounds and some diarrhea. You'll see tall peak T waves on an EKG, as well as a flat P wave, widened QRS, prolonged PR interval. You'll see risk factors include medications like ACE inhibitors, NSAIDs, or potassium-sparing diuretics, excessive potassium intake, kidney disease or dialysis because of decreased potassium excretion, Addison's disease, tissue damage, acidosis, hypersemia or hypercatabolism. Nursing interventions, we're going to monitor EKGs. We're going to restrict potassium intake, avoiding salt substitutes, discontinue an IV or PO potassium, prepare potassium secreting diuretics, prepare client for dialysis, prepare IV calcium gluconate and IV sodium bicarbonate. And it's also important to note that potassium and sodium are opposites. So if potassium is increased, the sodium is most likely going to be decreased, and vice versa. If we come over to sodium imbalances, we have hyponatremia and hypernatremia. So hyponatremia is when the sodium is less than 135, and this is going to lead to a decreased specific gravity. Cardiovascularly, we'll see normal volemic, so rapid pulse, normal blood pressure. We may see hypovolemics, they might have thready, weak pulse, hypotension, flat neck veins, or we may see hypervolemic, a rapid bounding pulse, normal or elevated BP. Respiratory will be shallow, ineffective breathing. This is a late sign. Neuromuscularly, we'll see skeletal muscle weakness, decreased deep tendon reflexes. We may see headaches, confusion, seizures, coma, personality changes. Gastrointestinally, they may have increased motility and increased bowel sounds, nausea, abdominal cramps, and diarrhea. They may have increased urine output and dry mucous membranes. Risk factors include an increased sodium excretion from diaphoresis or high fever, diuretics like loop or thiazide, diarrhea and vomiting, drains but not suction, decreased excretion of aldosterone, may have symptom of antidiuretic hormone, adrenal insufficiency, inadequate sodium intake from fasting or NPO, kidney disease, and heart failure. Our nursing interventions will be to administer IV chloride, diuretics if due to hypervolemia, daily weights, safety, so monitoring and assessing for falls or orthostatic hypotension, airway protection. They may be NPO if lethargic, limit water intake if there's hypervolemia, and teach about foods that contain salt, such as bacon, butter, canned foods, cheese, milk, condiments, salt, and bread. Then there is hypernatremia, so anything greater than 145, and they usually have increased specific gravity. So cardiovascularly, we're going to see heart rate and blood pressure will depend on vascular volumes. Respiratory pulmonary edema if they have hypervolemia. Neuromuscularly, early we'll see muscle twitching, irregular muscle conditions. Late we'll see muscle weakness and decreased deep tendon reflexes. Central nervous system will see altered cerebral function. They may be normal volemic or hypovolemic. They may have agitation, confusion, seizures. Hypervolemia, they'll have lethargy, stupor, and coma. Gastrointestinally, they may have increased thirst. They may have decreased urine output, dry flushed skin, dry sticky tongue and mucous membranes, and edema. On an EK or risk factors, we are going to see increased sodium intake. So they may have oral sodium intake, IV solutions with sodium, or hypotonic IV solutions. They may have, or they could have a loss of fluid. So that would be fever, diarrhea, diabetes insipidus, excessive sweat, and infection. And they may have decreased sodium excretion from kidney problems. Our nursing interventions, if it's due to fluid loss, we'll administer IV fluids. If it's due to inadequate renal secretion, they may need diuretics that increase sodium loss. We may need to restrict sodium and fluid intake. So a way I like to remember potassium and sodium is potassium is usually related to cardiac signs and symptoms, and sodium is usually related to the brain and signs and symptoms with the brain. So the big things for potassium, we're watching for those EKG changes, and sodium, you're typically going to see mental status changes. So then we also have calcium imbalance and magnesium imbalance. Typically, as calcium increases, magnesium also increases. So they are the same. It's a good thing to remember. And calcium and phosphate are the opposites. Calcium imbalance, we have hypocalcemia and hypercalcemia. So hypocalcemia is anything less than 9. Cardiovascularly, we'll see decrease of heart rate, decrease of blood pressure, and decrease of peripheral pulses. We'll see irritable skeletal muscles, so twitches, cramps, tetany, seizures, painful muscle spasms in the calf or foot, paresthesia following by numbness that may affect the lips, nose, ears, and limbs, increased deep tendon reflexes, anxiety, and irritability. Gastrointestinally, we'll see increased motility and increase of bowel sounds. They also may have abdominal cramps and diarrhea. For EKG changes, there may be a prolonged ST interval and a prolonged QT interval. Risk factors include inhibition of calcium absorption in the GI tract and increased calcium excretion, which could be through wound drainage, diarrhea, kidney disease, conditions that decrease ionized fraction of calcium. And our nursing interventions include calcium supplementation through oral or IV, administering vitamin D and aluminum hydroxide, initiate seizure precautions, and consume foods high in calcium. So foods high in calcium include cheese, milk, spinach, yogurt, tofu, sardines, and greens. A patient with calcium imbalance is at risk for fractures. Move the client carefully and assist with ambulation. Also, we would look for positive Trousseau signs or positive Chauvet sign. So positive Trousseau sign is a carpal spasm induced by inflating a blood pressure cuff above the systolic pressure for a few minutes. So you put a blood pressure cuff on, you inflate it, and you look for that carpal spasm. So their arm will kind of come in like this. Positive Chauvet sign is contraction of facial muscles in response to a light tap over the facial nerve in front of the ear. So that is, you'll just tap on their face in front of their ear and they get this contraction of facial muscles. For hypercalcemia, we will see early an increased heart rate, and then late we'll see bradycardia that can cause cardiac arrest. There will be bounding full peripheral pulses. We may see ineffective respiratory movement as a result of profound muscle weakness. We may see decreased deep tendon reflexes, disorientation, lethargy, and coma. EKG changes will see shortened ST segments and widened T waves. Risk factors: increased calcium absorption, decreased calcium excretion, kidney disease, thiazide diuretics, hypoparathyroidism or hyperthyroidism, malignancy, which could occur for bone destruction of tumors, and hemoconcentration. Nursing interventions are to discontinue the thiazide diuretics or IV PO calcium. Make sure to monitor EKGs and neurostatus. We can use loop diuretics, encourage fluids, or restrict dietary calcium. Then we are going to have magnesium imbalances, so hypomagnesemia and hypermagnesemia. So with hypomagnesemia, it's going to be anything less than 1.3. Cardiovascularly, we'll see tachycardia, hypertension, shallow respiration, twitches, paresthesia. We will see the positive Trousseau's and Chauvet sign, hyperreflexes, tetany, seizures, increased motility and hyperactive bowel sounds, and abdominal cramps and diarrhea. We will also see EKG changes as tall T waves, depressed ST segments. Risk factors include insufficient magnesium intake from malnutrition, celiac or Crohn's disease, vomiting, and diarrhea, increased magnesium excretion from diuretics, alcoholism, hyperglycemia and insulin administration, and sepsis. And our nursing interventions include magnesium sulfate IV or PO, seizure precautions, and increased magnesium-containing foods. And magnesium-containing foods are avocados, leafy greens, milk, wheat, peanut butter, pork, beef, chicken, potatoes, yogurt. Hypermagnesemia is anything greater than 10.5. For these patients, we'll see bradycardia, hypotension, respiratory insufficiency when the skeletal muscles of respiration system are involved. We'll see diminished or absent deep tendon reflexes, skeletal muscle weakness, drowsiness, lethargy. For a magnesium overdose, calcium gluconate is the antidote. EKG changes will see shortened ST segments and widened T waves. Risk factors are increased magnesium intake from antacids or IV magnesium, diabetic ketoacidosis, renal insufficiency, which will have a decreased excretion of magnesium. And our nursing interventions are diuretics, IV administration of calcium gluconate, restrict the intake of magnesium-containing foods, avoid laxatives or antacids with magnesium, and hemodialysis. So one of the ways I like to remember calcium and magnesium is, so they are the same. So when you see the signs and symptoms for hypocalcemia, they're going to be pretty much the same signs and symptoms for hypomagnesium, and same for hypercalcemia and hypermagnesemia. Now, when calcium and magnesium are low, that is when we really see the neuromuscular increase. So that's, you're seeing twitches and cramps and tetany and seizures. So that's when you're going to get the positive Trousseau's and Chvosnik's sign, because those are both of those muscles are just, they're spasming. So that is how I like to remember those. And then also the opposite. So hypercalcemia and hypermagnesemia. The way I remember this is, if you guys have ever taken that Calm stuff, it's like a powder you can get at CVS. It just makes your muscles relax. That is magnesium. So high levels of magnesium and high levels of calcium relax the muscles. So it's the opposite. All right. And last one, phosphorus imbalance. So we have hypophosphatemia and hyperphosphatemia. So hypophosphatemia is anything less than 2.5. Cardiovascularly, we're going to see decreased contractility and cardiac output, slow peripheral pulses. We may see shallow respirations. These patients may be weak, have decreased deep tendon reflexes, decreased bone density, and rhabdomyolysis. We may see irritability, confusion, and seizures. For risk factors, glucose administration or insulin release, respiratory alkalosis, malabsorption, diarrhea and vomiting, aldosteronism, and diuretic therapy. Nursing interventions are neurological assessment and phosphate supplementation as prescribed. And foods with phosphorus are fish, pumpkin, nuts, pork, beef, chicken, whole grains, and dairy. With hyperphosphatemia, it's anything greater than 4.5. Early, we'll see an increased heart rate, but late we'll see bradycardia that can cause cardiac arrest. We will feel bounding full pulses. Respiratory, they may have ineffective respiratory movement as a result of profound muscle weakness. Neuromuscular, so we'll see that muscle weakness, diminished or absent deep tendon reflexes, disorientation, lethargy, coma. Gastrointestinally, we'll see decreased mobility and hypoactive bowel sounds. Risk factors are renal disease, hypoparathyroidism or hyperthyroid, excessive vitamin D intake, muscle necrosis, excessive phosphate intake, and chemotherapy. And we'll assess for signs of hypocalcemia, teach patients to avoid foods and medications with phosphorus, and administer phosphorus binding antacids, and prepare patient for possible dialysis. And again, remember that when calcium is high, phosphorus is low. All right, and remember that you can get a printout of those on that link down below from my website. All right, so let's talk the pathophysiology. So there are different concentrations. So electrolyte concentrations vary from those in the cell and those outside of the cell. Sodium ions outnumber any other cation in the extracellular fluid. Therefore, it is essential in the fluid regulation of the body. Potassium, the extracellular fluid, has a low concentration of potassium and can tolerate only small changes in this concentration. The body uses a lot of energy in maintaining sodium and potassium concentrations throughout the cell membrane pumps that exchange sodium and potassium ions. And when two different solutions are separated by a membrane that is impermeable to the dissolved substances, fluid shifts from a region of low solute concentration to high solute concentration until the solutions are equal. So this is osmosis. So if you know that the body wants to create homeostasis by moving those particles to equal amounts on both sides of the cell. So where there is an amount of high concentration and the area of low concentration, those solutes want to move from the area of high to low to create a balance. But if they can't move, another thing the body can do is shift the fluids. So if you have an area of low concentration on one side and an area of high concentration on the other, and we can't move the particles, the fluid will shift from the area of low to the area of high to try to create that balance. There's also diffusion, which is the natural tendency of the substances to move from one area of higher concentration to the area of low. So causes of fluid and electrolyte imbalances are fluid retention. So the retention of sodium is associated with fluid retention. There's loss of sodium. So excessive loss of sodium is associated with decreased volume of body fluids. Trauma can release intracellular potassium, which is extremely dangerous. Loss of body fluids occurs more rapidly when coupled with decreased fluid intake. And fluid volume deficits result from loss of body fluids. There's also fluid overload, so fluid volume excess may be related to a simple fluid overload or diminished function of homeostatic mechanisms responsible for regulating balance. And there can also be low or high electrolyte intakes from diet, which can also cause electrolyte imbalances, and certain medications can cause electrolyte imbalances if they're not taken correctly. So clinical manifestations that we can watch for include fluid volume deficits. So we would see acute weight loss, decreased skin turgor, algeria, concentrated urine, orthostatic hypertension, a weak rapid pulse, flattened neck veins, increased temperature, thirst, decrease of delayed capillary refill, cool clammy skin, muscle weakness, and cramps. We'd also see fluid volume excess, which includes edema, distended neck veins, and crackles. A summary, so we went in depth with these different electrolyte imbalances, but I'm going to give you quick summaries. So hyponatremia, so that is low sodium. We can have anorexia, nausea, vomiting, headache, lethargy, dizziness, confusion, muscle cramps, weakness, muscle twitching, seizures, dry skin, and edema. We also have hypernatremia, so high sodium. These signs and symptoms will include thirst, elevated body temperature, can even be hallucinations, lethargy, restlessness, pulmonary edema, twitching, increased blood pressure, and an increased pulse. Hypokalemia, so low potassium. You'll see fatigue, anorexia, muscle weakness, polyuria, decreased bowel movements, paresthesia, ileus, abdominal distension, and hypoactive reflexes. Hyperkalemia, so high potassium. You'll see muscle weakness, tachycardia, paresthesia, dysrhythmias, internal colic, cramps, abdominal distension, and anxiety. Hypocalcemia, so low calcium. You will see numbness, tingling of the fingers, toes, positive Trousseau sign and Chauvinux sign, seizures, hyperactive deep tendon reflexes, irritability, or bronchospasm. Hypercalcemia, so high calcium. You'll see muscle weakness, constipation, anorexia, nausea, vomiting, dehydration. Hypoactive deep tendon reflexes, lethargy, calcium stones, flank pain, pathological fractures, and deep bone pain. Hypomagnesemia, so low magnesium. You will see neuromuscular irritability, positive Trousseau's and Chauvinux sign, insomnia, mood changes, anorexia, vomiting, and increased deep tendon reflexes. Hypermagnesemia, so high magnesium. You will see flushing, hypotension, muscle weakness, drowsiness, hypoactive reflexes, depressed respirations, and diaphoresis. Hypophosphatemia, so low phosphorus, you'll see, so low phosphate, you will see paresthesia, muscle weakness, bone pain, and tenderness, chest pain, confusion, seizures, tissue hypoxia, and nystagmus. And hyperphosphatemia, which is high phosphate, you will see tetany, tachycardia, anorexia, nausea, vomiting, muscle weakness, and hyperactive reflexes. So different complications we can see with fluid and electrolyte imbalances are dehydration, so a fluid volume deficit, cardiac overload from fluid volume excess, symptom of antidiuretic hormone. You can see when water is retained abnormally, and cardiac arrest if there is too much potassium administered. So as the nurse, our assessment and diagnostic findings are going to include looking at the BUN, which can be decreased in fluid volume excess due to plasma dilation. We're going to look at hematocrit. So levels in fluid volume deficit are greater than normal because there is decreased plasma volume. We're going to do a physical exam to observe signs and symptoms of imbalances. We're going to look at serum electrolyte levels to check for imbalances. We're going to look at EKGs to see if any changes due to fluid and electrolyte imbalances. And we're going to look at arterial blood gases to analyze acid-base imbalances. So our medical management is going to include isotonic electrolyte solutions. These are used to treat hypotensive patients with fluid volume deficit because they expand plasma volume. We're going to do accurate INOs and frequent assessments of INO to prevent volume deficit or overload. Can also use dialysis. So hemodialysis or peritoneal dialysis is performed to remove nitrogenous waste and control potassium and acid-base balances and to remove sodium in fluid. And nutritional therapy. So treatment of fluid and electrolyte imbalances should involve restrictions or enforcements of certain electrolytes. We can also look at pharmacological therapy. So there are AVP receptor agonists. These are a new pharmacological agent that treat hyponatremia by stimulating free water excretion. There are diuretics to decrease fluid volume and fluid volume excess. There are IV calcium gluconate. If serum potassium levels are dangerously elevated, we administer this by IV. And there's calcitonin, which is used to lower serum calcium levels and particularly useful for patients with heart disease or heart failure that cannot tolerate large sodium loads. So our nursing assessment, we're again looking at those I's and O's at least every 8 hours, but can even be as often as hourly. We're going to do daily weights to measure gains and losses. We're going to look at vital signs, and we're going to do physical exams to assess for fluid and electrolyte imbalances. These are just some different diagnoses that we can use when assessing fluid and electrolyte imbalances. So excessive fluid volume related to excess fluid intake and sodium intake, deficient fluid volume related to active fluid loss or failure of regulatory mechanisms, imbalanced nutrition less than body's requirements related to inability to ingest food or absorb nutrients, imbalanced nutrition more than body's requirements related to excessive intake, and diarrhea related to adverse effects of medications or malabsorption. Our nursing care plan goals can include things like maintenance of fluid volume at a functional level, display of normal laboratory values, demonstrate appropriate changes in lifestyle and behaviors, including eating patterns and food quality and quantity, and reestablishment and maintenance of normal patterns in GI functioning. So our nursing interventions can include monitor turgor of skin, as these can indicate fluid status of the patient. We're going to look at urine concentration, so obtaining urine samples to check to see the urine concentration. We can also use oral and parenteral fluids to correct deficits. We can use oral rehydration fluids, also glucose and electrolytes. We can just be aware of central nervous system changes, and we want to be monitoring for these as they can look like lethargy, lead to seizures, they can have confusion, muscle twitching. And we can also adjust the diet, so we can encourage the intake of electrolytes that are deficient or restrict the intake of electrolytes that are excessive. Our evaluation is going to include, these are just some examples depending on what the outcome of your patient was. So maintained fluid volume at a functional level, displayed normal laboratory values, demonstrated appropriate changes in lifestyle and behaviors, including eating patterns and food quality and quantity, and reestablished and maintained normal pattern of GI functioning. Our discharge and home care guidelines can include a diet rich in all the nutrients and electrolytes that a person needs and should be enforced, fluid intake according to recommendations of the physician, a follow-up. So after discharge, the patient should return for a follow-up checkup to evaluate the electrolyte and fluid status, and education about medications and to let the patient know they should be compliant with the medications prescribed, because we do not want the condition to reoccur, which will happen if the patient doesn't take their medications. All right, and our documentation for these patients will include individual findings, factors affecting the ability to manage body fluids and degree of deficit, I&O, fluid balance, changes in weights, urine-specific gravity and vital signs, results of those diagnostic tests and laboratory findings, our plan of care, the client's response to the plan of care and the teaching and treatment, attainment of progress towards desired outcome, and modifications to the plan of care. So if you guys like this video, make sure to give it a thumbs up and subscribe below, and also make sure to get that free study guide down below. And I hope that you enjoyed, and I will see you next time. Hope you find this helpful. Fluid and electrolyte imbalances can be confusing. Okay, bye.